Welcome to this reader feedback edition of Forthright. I'm Sulani Madsen. The following column was published Thursday, September 23rd in the Spokesman-Review, titled COVID-19, Unasked Questions. Rarely does one get an answer to an unasked question. When the media is dominated by a single narrative, stifled questions shut down critical conversations about public health and the healthcare system. As an alternative voice on the Spokesman-Review editorial page, I hear from the frustrated. When merely asking questions will get you publicly lambasted as a COVID-denying anti-vaxxer who doesn't care about other people's health, it's no surprise they wish to remain anonymous. One healthcare worker at Sacred Heart questions why we have patients living in a hospital for over a year. On average, 10 to 15% of all acute care beds are occupied by a category called difficult to discharge, according to the Washington State Hospital Association. Spokane's hospitals are no exception. These are patients who should be discharged to a long-term care facility, an adult family home, or go home with family. They significantly reduce hospital capacity for acute care. She describes these patients as suffering from dementia, developmental disabilities, or psychiatric problems who either have no family or no family able or willing to take them. She says, there is no place to put them, so they sit in the hospital. We need a system that takes care of everyone. Some were functional alcoholics until another illness landed them in the hospital, but they are no longer acutely sick. How many patients in Spokane hospitals are ready to be discharged but have no place to go? How many more acute care beds would be available if this hard-to-fix problem were addressed? How do we restructure the healthcare system to better care for those who cannot care for themselves? Why have we lost capacity in the long-term care system? Staffing shortages at every level of healthcare are part of the problem. Hospitals have been close to the edge for a long time, well before COVID. Washington and Idaho both had a shortage of just over 10 nurses per 1,000 population in 2018, according to nursejournal.org. A registered nurse working in a Spokane ICU said she constantly receives calls asking her to take extra shifts, noting the entire hospital is short-staffed in all units at every level. It's a prescription for burnout. Like every other industry, it's also hard to fill basic but invisible jobs. The hardworking nursing assistants who provide much of the hands-on personal care are critical for staffing beds. And anyone who has waited in a hotel lobby for a maid to flip a room can understand how environmental aides with healthcare housekeeping experience are critical to finding a bed. Did staff nursing layoffs in 2020 accelerate reliance on travelers? Are the memes claiming 500 job openings at some local hospitals true? Were staffing levels in 2019 higher or lower compared to 2020 throughout the system? Has the ratio of staffing to population kept up with population growth? And then there are the patients. Contrary to sensationalized national news, previous reporting in the Spokesman-Review affirmed the data does not show COVID patients from Idaho overflowing into Spokane hospitals. And I'll make a note that later reporting said there was some of that, now it's reversing. It's a shifting situation. Tracking addresses is easy. A more difficult question is whether a patient testing positive for SARS-CoV-2 virus actually has COVID-19, the illness. An ED physician at Sacred Heart pointed out every patient coming into the hospital is tested because staff must logically take precautions to limit cross-contamination. But that means a woman brought to the ICU for head trauma and asymptomatically positive is counted as a COVID patient, with the hospital gaining a bump in Medicare payments intended to cover additional isolation costs. And it leaves families telling now common tales of loved ones erroneously listed as dying from COVID when their problem was a heart attack or trauma. One medical coding professional who started to answer questions before remembering corporate protocol about talking to the media said, "Don't get me started, it's all screwed up." So how many patients have COVID as a primary diagnosis, and how many are merely identified as COVID patients for appropriate in-hospital quarantine? Will or should new rules from insurance companies related to COVID diagnosis affect coding? Is there Medicare billing fraud driven by a perverse incentive to overdiagnose COVID? The nurse who turns down extra shifts at Holy Family to preserve her mental health said she doesn't follow the news because she doesn't know whom to trust. What she currently sees in her ICU is about 3/4 of the patients coming in with the primary diagnosis of COVID, a higher proportion than last year. She says half are intubated and half of those won't make it. While she said about 80% of her ICU patients are unvaccinated, 20% are vaccinated, and many of those, she says, also got super sick and died from COVID. She wants to know, why aren't we talking about the effectiveness of natural immunity compared to vaccination? And since hospitals are already short-staffed, how are they planning to safely care for patients after losing staff when the vaccine mandate deadlines kick in? These questions are all from real people in the Spokane community with real lived experience. Respect their voices. Don't be afraid to ask their questions. It was fascinating how a column merely asking questions drew passionate responses. Let's hear from a naysayer. From Galen G., with whom I agreed on the long-standing problem of the difficult to discharge, but he objected to questioning the other variables impacting hospital capacity and who counts as a COVID patient. Yes, some of the people in the hospital with COVID have other diagnoses, but do you really think that we have had an epidemic of head traumas all of a sudden? And if there is fraud going on regarding upcoding, I suggest you go out there and find it. Galen goes on to say, as far as number of COVID patients who are vaccinated versus unvaccinated, those numbers are easily available and all hospitals are reporting in the 95% range of unvaccinated. 95% of ICU patients are using natural immunity versus 5% who are using vaccination. There is no evidence that anything increases natural immunity in a meaningful way other than COVID exposure or vaccination. Please stop spreading misinformation and do a basic Google search before printing your column. This is dangerous and infuriating. Your questions have been asked for months and answered multiple times during that time period. You just don't like the answers. Well, Galen, of course we have not had an epidemic of head trauma. But we do have an epidemic of statistical semantics, starting with the definition of vaccinated. A patient does not count as vaccinated unless they are 2 weeks past their final dose. There is a 3 to 6 week period of unvaccinated people, more properly called vaccination in progress, but that's a category that doesn't help justify the soundbite phrase, pandemic of the unvaccinated. As for how many patients are choosing to rely on natural immunity, patients are not coded by prior, confirmed, or presumed COVID infection. There is evidence for the value of natural immunity. Rockefeller Institute is one source indicating a short-term advantage to vaccination producing immunity, but longer-term value from having survived an infection, producing a stronger immunity. Many of those refusing vaccination at this point have already been exposed. And state and federal mandates which ignore that science and insist on vaccination only is counterproductive to moving forward as a healthy community. Galen suggested all of the questions can be answered with a, quote, basic Google search. But another correspondent I know is Dr. J points to the problem of too much information. Dr. J says, I quote, the questions you've dared to address are just the tip of the iceberg, a scratching of the surface. Perhaps a bigger problem than COVID is the inability of John Q. Public to find a reliable source for data. So many narratives exist. The media and educational institutions have viewable, measurable leanings toward agendas that are politically or financially motivated. Dr. J continues, in my opinion, perhaps the most egregious situation is that this counterculture of the cancel culture is being perpetrated by a minority of the population, a powerful minority, and as we have seen repeatedly throughout history, a powerful minority, when not adequately resisted, can dominate the majority and ultimately enslave them. End of quote. The appearance of a new virus has exposed and exacerbated the fault lines in our society. We have long approached healthcare as a service industry to be organized along the same lean production model as an Amazon warehouse with just-in-time delivery of medical care. It's efficient, it keeps costs down, and for those who have prime access because of their location or their membership in the right public or private insurance programs, it works great. Until a busy season comes along and we are reminded that hospitals can't be staffed up like warehouses to meet our needs. We need to rethink how we deliver health care for a return to the old normal of living with infectious disease. There is no zero COVID future. Some who have advocated for health care as a basic human right instead of a basic human need have insisted that no one should be denied access to health care. Now some of these same voices are insisting there's no right to health care for those who make unapproved choices on how to stay healthy or whose choices increase demand for services. No vaccination? You go to the end of the line, regardless of for the reason for why you did or did not or were not able to be vaccinated. Your right to health care is not an inalienable right when it exists at the pleasure of the government, but it is an inalienable need and a personal decision. My body, my choice. We must be very careful with giving our government power to compel medical decisions in the name of the public good, and especially careful when that power is not tempered by room for individual choices. Measles is 6 times more transmissible than the original strain of COVID-19, 2.6 times more transmissible than the Delta variant, and can have terrible complications for young children besides fatality. We have agreed to allow our government to require measles vaccination to attend government-run schools after weighing the collective and individual risk and reward. We do not require vaccination for chickenpox, which is 4 times as transmissible as the original COVID-19, and almost twice as transmissible as the Delta variant. Nor do we require flu shots. Flu is more deadly to children, and flu vaccines are notoriously hit or miss on reliability, since the vaccine makers must guess what variants will appear each year. Where there is risk and uncertainty, we leave choices to individuals. That principle of maximum individual freedom while protecting the vulnerable matters. While I am strongly pro-life and pro-woman, I do not support banning abortion. A government which can ban a medical procedure also has the power to compel a procedure, and it's trying to exercise that power now. Baby might be born with serious medical issues requiring labor-intensive and expensive care. Maybe baby has no right to health care, no inalienable right to life, liberty, and the pursuit of happiness. Want it or not, abortion it is. We justify abortion by declaring that preborn human beings are not persons. Which brings us to the fault line exposed by the vaccine mandates, or rather the reaction to the vaccine mandates. Not the reaction by those who are looking at the risks to them as individuals and deciding not to vaccinate now, but the reaction by those who would demonize them. In closing, this comment came in from a reader who often provides blunt feedback, sometimes pro, sometimes decidedly not, from Jim W. You've raised a lot of interesting questions about the accuracy of COVID-19 illness and mortality reporting. The questions you raised are really serious if the implications turn out to have any basis in fact. So what say you finish the job and answer those questions instead of just leaving them out there like veiled accusations of fraud? I'm not being sarcastic here. Side note, sometimes he is. But Jim goes on to say, I sincerely think you have raised a series of questions an investigative reporter would salivate over the opportunity to research and report. Well, Jim, I would love to dig in, and I hope a full-time investigative reporter takes up the challenge. But first, they have to be willing to resist an angry cancel culture demonizing anyone and any publication which dares to question the popular narrative as a dangerous and infuriating spreader of misinformation. That's all for this edition of Forthright. Thank you for joining me.